Hello, and welcome to Shadow Me Next, a podcast where I take you into and behind the scenes of the medical world to provide you with a deeper understanding of the human side of medicine. I'm Ashley, a physician assistant, medical editor, clinical preceptor, and the creator of Shadow Me Next. It is my pleasure to introduce you to incredible members of the healthcare field and uncover their unique stories, the joys and challenges they face, and what drives them in their careers. It's access you want and stories you need. Whether you're a pre-health student or simply curious about the healthcare field, I invite you to join me as we take a conversational and personal look into the lives and minds of leaders in medicine. I don't want you to miss a single one of these conversations, so make sure that you subscribe to this podcast, which will automatically notify you when new episodes are dropped, and follow us on Instagram and Facebook at Shadow Me Next, where we will review highlights from this conversation and where I'll give you sneak previews of our upcoming guests. Some careers in medicine are about speed, some are about precision, and some are about sitting with people in the quiet, hardest moments of their lives. Today's guest knew he wanted to be a pediatrician at 12 years old, but it was a single rotation in sleep medicine that altered his course. What followed was a career shaped by listening, theology, emotional intelligence, and an understanding that healing is not always technical. Sometimes it's deeply human. Dr. Benjamin Long is a dual board-certified sleep medicine physician and pediatrician, a military physician, and the author of a sleep habits journal. In this conversation, we talk about burnout, insomnia, faith, overthinking, and what it really means to accompany someone through suffering. Please keep in mind that the content of this podcast is intended for informational and entertainment purposes only and should not be considered as professional medical advice. The views and opinions expressed in this podcast are those of the host and guests and do not necessarily reflect the official policy or position of any other agency, organization, employer, or company. This is Shadow Me Next with Dr. Benjamin Long. Thank you so much for joining me on Shadow Me Next today. I've already told you how convicting for me this conversation is going to be, how much we are going to learn about something that everybody always complains about and almost wears as a badge of honor, but yet is not interested in really working to fix it. And we're going to highlight why they need to be interested in that today. So thanks for being here.
I'm so excited to be here. Thank you for having me on.
So let's talk a little bit about your background. You are a dual board certified sleep medicine physician and pediatrician. For those listening, tell us what this means. What does it mean to be dual board certified?
Yeah, when you think about specializing in medicine, most of the time it's pretty straightforward with like, I'm a did a pediatrics residency, and then I go and jump in to do pediatric gastroenterology. But the reason I use the language dual board certified is because even though my niche is pediatric sleep, I'm board certified through a partnership between the American Board of Pediatrics and the American Board of Internal Medicine to see all ages of sleep. So it's this really interesting thing. The most prominently, you can get it in sleep medicine, and allergy is another similar place where you can come from a different residency core specialty to be able to really, in a way, practice a totally different field of medicine. And instead of, like, in my view, where so many specialties kind of narrow down to your, not just kids, but kids who have stomach or heart problems, it's like I was able to kind of go through a door and almost enter a totally new world where I could see all ages for sleep medicine.
Thank you so much for describing that. So it's so interesting because I think this is one of those questions that pre-health students have a lot, right? Is Ashley, I'm really worried that if I go to medical school and I become a doctor, I'm going to be pigeonholed into one specialty for the rest of my life. And I'm 21 years old and I can't plan the rest of my life right now. I don't know what I am going to have for dinner, let alone what I want to practice for the next 4 decades. But what you've described really is some flexibility there, which is actually really nice. And the question I have for you is almost a chicken or the egg question, which came first. Did you know you wanted to, when you first started thinking about medicine, did you know you wanted to become a pediatrician and then found an interest in sleep medicine, or was it the other way around?
Definitely the first. My grandfather was a pediatrician in Columbus, Georgia
Oh.
for very long time. I even have memories of going up to the hospital with him as like a kid and like sitting at the nurse's station and like kind of doing rounds. I guess this was like pre-HIPAA kind of thing. So that was really formative for me. And anytime I would go anywhere with my grandfather, it was like Dr. Sizemore. We would always run into someone. Kids were like running up to him and stuff like that. So that was like this big thing in my mind. And so I made a decision to be a pediatrician like when I was 12. I feel like a lot of pre-med students, and then once we got into medical school, it was like people like me who were like, I knew from a very young age I wanted to do this. And then I would meet these people who were like, I just decided, yeah, I'll give medicine a try. And I'm like, what? What are you talking about? Like, you mean this hasn't been like your goal for the past like 10 years or half your life kind of a thing? Um, and so I, continued on that trajectory. And really, I got towards the end of my pediatrics residency and I kind of, I was like head down, work, 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 work. And like looked up and I was like, oh, I don't know if this is what I want to do because
Mm.
I almost had a little bit of the rose-colored glasses on because I was like the kind of stories and the what I witnessed with my grandfather and how he practiced that exists, but it's more rare these days. And so some of it definitely was self-preservation, I think. Um,
Mm.
but also I just happen to rotate on sleep. And, we often talk about click moments in medicine where you have the undecided student who like, I don't know. And then you rotate on something and it just clicks. That was exactly it for me in sleep. My first patient was the pediatric sleep clinic. And it was a kid who had kind of like a complex medical history that I was familiar with as a pediatrics resident. So the staff sent me in there, and it was just this really different flow of the conversation. And um, the the cool thing about sleep is that it's like whenever you can fix someone's sleep, they're so happy.
Yes.
Like so, and it's so some of it is a little bit of like immediate like feedback too. Like by the second or third follow up, usually people are like, "Oh yeah, I'm doing so much better," or "No, it's still not helping," and then I kind of have to continue down that road. Um, so yeah, I to the point that when I was an intern, I was in like an orientation breakout group that was led by a sleep medicine fellow that year. And I was like, sleep medicine, who wants to do that? And it turned out it was me. So
That was you. Oh, that is such a cool thing. And that's kind of what I expected was that you enter medicine and like you said, from 12 years old, you knew this is what you wanted to do. And I do want to talk about your grandfather here in just a minute. You enter medicine, you fall in love with medicine, you all of a sudden see behind the curtain of medicine, and then something catches your eye, is really kind of the visual that I'm hearing now. And I think sometimes it does take a bit of bravery to follow that. Like you said, who wants to do sleep medicine? Oh, wait a second. Well, perhaps that is me. Thank you for describing that. It's a really cool journey. Let's go back and talk about your grandfather for just a second. Because you
yeah.
mentioned something that I think will be really, really helpful to our pre-health students. And that is really the magic of medicine is what you got to see when you were 12 years old, right? And the
Yeah.
nurses and the banter with the nurses and the respect that your grandfather really had earned with
Hmm.
his families and the kiddos. And you mentioned what you saw with him does still exist, but it's also changed, right?
Yeah.
Let's give our pre-health students a peek behind the curtain. What are you talking about when you say those things?
Yeah. I think one thing is that there definitely are still opportunities where you can, especially go into like a primary care field and go to a small town and you are integrated into the fabric of that community
Mm-hmm.
in a very real way. There are voices online right now, and there's a little bit of a conversation around should I consider medicine as a calling or is this just like a job like any other job?
Mm-hmm.
Um, the funny part about medicine is there's a lot of a um, whether you want to call it a philosophy, worldview, I would argue even a theology of how I go into that we're not trained to understand or talk about really, but that undergirds so much of how we go about doing our job as practitioners.
Mm-hmm.
And um, and so I've seen this trend online of more people like this is just like a job, 9 to 5, like any other thing. And in certain systems where um, you don't necessarily have that control over your schedule, or um, the autonomy as much to make some of those decisions, then that is a little bit of a self-preservation. And it's kind of like, okay, I'm going to clock in, clock out because that's what this system demands of me if I'm going to survive here. But there are other opportunities where you can, control your own schedule. You can be integrated into a community and, you know, find connections and fulfillment in a way that is that kind of like older medicine. I do have a story. So for a long period, I have actually been in the military as a military practitioner. And so the real beautiful thing is when we lived up in Alaska, we lived on base. And so really every single child who was on my street was a part of my clinic.
Wow.
And so I had moms with newborn babies come knock in the middle of the night and they're like, "Oh my gosh, can you just check on my baby?" And that's very rare. I would offer to all of my neighbors, "Hey, call, like if I can be your kind of checkpoint so that way you're not spending the next 4 hours in your ER, then yes, please utilize me in that capacity." And people actually didn't take me up on that offer as much as I thought they would, because most people would be like, "Oh, I don't want to be a bother," kind of a thing.
Yes.
And so I had newborn babies on my dining room table. I had, went over to a neighbor's house and diagnosed a pneumonia and stuff like that. And it was so fulfilling because it was like, these are people I know that I love and they're so appreciative. And so it just hits way differently. And I was like, this must have been what medicine used to be like. And I know that is still possible and still exists. It's just, you have to find it.
You do. And you have to fight for it too, I think sometimes. I kind of have goosebumps thinking about that. It's what I think we all really, really desire just for general care. When we are in emergent situations or when we are in really significant diagnostic, the throes of a bad diagnosis.
Yeah.
Those things become a little bit less important, right? We just need somebody to help us, to fix us, to make us better. When it comes to our care as humans, and you mentioned theology, and I am very excited to dive into that because it plays a big part in who you are and how you practice. But, a whole person care, it does require relationships. In my opinion, it really does. I think it makes patients feel more heard. And I think the visits become more cooperative, and ultimately they end up with a better lifestyle because of their relationship with the person who's helping them with their health. You mentioned how people don't take advantage often when you really open yourself up as a clinician and a person. And I would absolutely agree with that. Especially recently, the number of times I've given my cell phone to patients, with the exact same instructions. "Please call me if you have any questions about anything." It's not so much a workaround. It's just, I want you to feel like you have access and that people are available to you.
Yeah.
They rarely call, ever, hardly ever. If anything, I get a Merry Christmas text as opposed to a phone call about a health issue, So it is really lovely. And I thank you for describing all of that. I think it's important that students realize that it's not always rainbows and butterflies, but there is still a lot of goodness here in medicine. And you do sometimes have to seek it out, but it's there. Yeah. Let's pivot just a bit because I would really love to hear a little bit about sleep medicine and what that practice looks like for you. So describe a day to us where you're focused on taking care of people with disordered sleeping.
Yeah. I've been in a really unique situation for a lot of my military career, and that actually I split my time between my sleep practice and my general pediatrics practice. So I really have done both for my attending career to this point. A typical day in the sleep medicine clinic is, going in. Most people will kind of have half days of or some time kind of in between to actually read sleep studies versus seeing patients in clinic. So those are kind of the two points there. You've got several different kinds of sleep studies. You have the ones a lot that you see that you can just do at home versus the full get up where you have, leads on your head for the EEG, on your eyes, the nasal cannula, chest bands, stuff on your finger and all this stuff. And then they're like, oh, also, by the way, there's a camera over there watching you go to sleep. So super comfortable. And so then we read all of that data for a night and kind of create a report based on that. So that's kind of one side of sleep medicine. I think a lot of practitioners really enjoy that part because there's a little bit more flexibility in that compared to having the demands of appointments back to back. And then for me, a typical day as my niche is pediatric sleep is doing a pediatric sleep clinic. And so that's where I'm having patients that sometimes it might be a classic 7-year-old child with, huge tonsils and mom shows me a video and the kid's like, I'm like, yeah, you need to get a sleep study, kind of a thing. That kind of goes down that direction. A lot of times for pediatrics, behavioral. And so I made it a priority in my fellowship and my training to really make sure that I was comfortable with the behavioral sleep problems that occur in pediatrics. And so that's everything from that we think of like babies who are having difficulty around sleep training. We could have a very long conversation on that because there's so much misinformation out on the internet with that right now. And I couldn't tell you the number of times, I'm not exaggerating, mothers sitting in front of me crying because they're so afraid to do anything and they don't know who to believe and they don't know what to do. And really it's just a matter of I'm present, a slight tangent, where there's so many conversations around AI and concerns about it overtaking our jobs. But in that moment, that's something that AI is not going to be able to do. Is there is something to the human component of accompanying people in their illness experience that great. If AI can diagnose better than me, yes, like we want that. That is a good thing. But we'll always need people who are going to be able to bear witness to suffering and accompany people through that as well. And that's how I view my time in the clinic with my families is they are on a journey through the sleepless night and I am accompanying them through that.
Here on Shadow Me Next, we include what we call quality questions in every episode because medicine is not just about what you know, it's about who you are when things are hard. This is the kind of question you may hear in an interview. It's also the kind of question you will have to answer in real life, whether you are ready to or not. So today's quality question is this: tell me about a time you witnessed suffering. How did it affect you? This is not about having the perfect story. It's about awareness. It's about whether you notice what is happening around you and if you are willing to sit with it. If you're preparing for healthcare, I want you to think about this one. Let it challenge you a little because medicine certainly will. Keep in mind that there's more interview prep, such as mock interviews and personal statement review over on shadowmenext.com. There you'll find amazing resources to help you as you prepare to answer your own quality questions.
And it's just a matter of tell me your story. What tools do I have that can help you along your journey? And let's continue to see where that leads. And yeah, that's a typical day in the sleep clinic for me.
I love that. I can only imagine the frustration that a lot of your patients feel. And I do want to ask in a second, sometimes how that frustration might manifest in clinic as well. But before we get there, there's a question that I'm very interested in, and that is it ties back to what you mentioned with theology, and you've used phrases like bearing witness to suffering, things like that are very difficult things to walk through as a physician, as a clinician, right? However, you have a really good support system, but many people, they'll lie awake at night because of, a million things. Maybe not caffeine in kids, but caffeine in adults or screen time. But from your perspective, how often is insomnia, you mentioned this a little bit with behavioral, how often is insomnia an emotional or a spiritual signal rather than an actual sleep disorder?
The more I've gone on a journey of, thinking, how can I integrate theology and medicine and how I practice and how I care for my patients? I really do see those things as aspects of the same thing. When we're talking about mind, psyche, emotions, spirit, in a way, we're really describing all the same thing. Not to get too philosophical too quickly, but too often we talk about the neuroanatomy correlates of behaviors and emotions and things like that. And that is very important. If someone has an overactive amygdala, then obviously that is going to play out in a very different way from someone who doesn't have those things. But you can lead yourself into what's called the fallacy of misplaced concreteness, which is where you assume that the brain scan, the brain, that physical thing is the same thing as that emotional experience. And those aren't the two same things, because if you think about it in some way, we still don't even have like a physical explanation for consciousness or a physical explanation for dreams and memories. Yes, a neurosurgeon could probe your brain to, spark some memory, but they're never going to be able to spark the exact same memory and duplicate that amongst people. That's crazy. That's crazy, So that's why there are these mysteries still within medicine that, yes, we have amazing, powerful tools to be able to help us to treat and accompany our patients. But as I progressed through my medical education, I realized there's something else that was missing. And like I said, all of us are operating out of some kind of worldview. And whether you like it or not, you are operating out of some kind of theology. For people who aren't familiar, theology is just the study of God and God's relationship to creation. And so if I believe that there is no God, I am operating out of a theology that there is no God. And that's going to extend to my patients as well. And so back to your question on insomnia and kind of those barriers, I would say that is very common. The reason why the first line treatment for insomnia, the one that we come back to that we know has the best evidence behind it, is cognitive behavioral therapy for insomnia. It's down to your thoughts and your behaviors and how those become barriers to good sleep. And so that's why in my practice, not only do I get a social history for people, but I also do a spiritual history, which is very simple. I just ask, is spirituality or religion an important part of your daily life? If my patient says no, nope. And then we continue and we have the same kind of conversation that we would normally have. But if you would ask me, what is the one question that changes the whole conversation, I would say it's that one, because sometimes people say yes, and we go in a totally different direction. And it always influences the conversation, because in one way, I feel like I do have a fuller vision of my patient and understanding who they are. But in another way, sometimes it really is the thing that is interrupting their sleep. Some people can't help it when they're having a faith existential crisis, or unfortunately, when they have experienced real religious hurt or church hurt, or to the extent of religious trauma, of those things. And that being in a medical space, it's not always, I think patients often feel like this isn't the place to necessarily talk about that per se. And so by me asking that question, I open that door and they know that they are safe to present that side of themselves. In the same way, it's funny because as your pre-med students get into medical school, we will ask a full sexual history. We will ask how you do it, where do things go, how often, and go down that list and not blush. But then it's so funny when I talk to colleagues sometimes and I talk about a spiritual history, and then all of a sudden they're like, oh, that might make people uncomfortable. And I'm like, really? Like, oh, okay. So it is this really odd, interesting thing. But it definitely can, when it does inform the situation and the sleep problem, then it kind of gives you the keys to have that conversation, versus if you're not even asking the question, then you might be shooting yourself in the foot a little bit.
It's such an interesting take. And one, I mean, I've worked in medicine for how long, never considered all of it is extremely private, and every
Hmm.
conversation could be viewed as being highly uncomfortable, right?
Yep.
So to
Yep.
think of one as being extremely normal and the other one is being totally off limits is just, oh my gosh, it's just so interesting. Okay, talking about disordered sleep.
Hmm.
Obviously, there's a million different definitions of disordered sleep, right? Difficulty falling asleep, difficulty staying asleep, difficulty waking up, things like that.
Hmm.
But let's talk a little bit about the emotions of that. You mentioned mothers sitting there sobbing, crying just because they don't know what to do. There's a lot of emotion when it comes to sleep. Describe for us some of the emotions that play into these sleep disorders that you're dealing with on a daily basis, some that maybe cause the disordered sleep or perhaps might stem from disordered sleep.
Yeah. I'd say a real common archetype or profile to an insomnia that I see is the overthinker, is what I call
Mm,
it, where that worry and anxiety can create a huge barrier to sleep. And so, especially, I'm sure you have a lot of listeners who they're worrying about their finals, they're worrying about their
mhm,
applications, they're worrying about their job shadowing, they're worrying about all these kind of things. And that is what's kind of like playing in the night. So, as far as just common, that would definitely be a big one.
mhm,
And, sleep is this unfortunate vicious cycle in a way where
mhm,
when you have sleep deprivation, going back to those brain imaging studies, your prefrontal cortex that is having like less functioning, and so that's your ability to plan, your attention,
mm,
all of those kind of things from the top side, and then your basal ganglia, so then parts of the brain that are more of the emotions, like the amygdala and stuff of that nature, those are going higher, and so it's kind of like what we are the part of our brain that is supposed to kind of help us get through our normal daily lives and a lot of our cognitive functions, that's going down, our emotions are going up, and so then that's why you get more of the I'm I just feel like I'm all over the place, I'm moody, I'm
mhm.
impulsive, or things of that nature when you're getting poor sleep. And so often when you're experiencing that, then you're worrying more, and that can kind of get you into this vicious cycle that can be hard to break.
And if you're listening and you're thinking, oh my goodness, this is me, I need help here, I would highly recommend you check out Dr. Long's book. It's called Sleep Habits Journal Practices, Prayers, and Devotions to Ease Your Sleepless Nights. This book is incredible. It blends biblical reflections, which I would imagine is great even for people who would not call themselves Christian, right? Or followers of the Bible. Guided prayers, journaling prompts with tools that are proven from sleep medicine to help you calm your anxious heart and invite the Lord's presence into restless nights. It just sounds incredible. I am Furthermore, the cover of this book is gorgeous. You guys, please check it out. Before we wrap up, Dr. Long, I do want to ask, what is one simple practical thing that our listener can begin to do right now to help experience better rest aside from buying your book?
Yeah. Yeah, of course. Um, I would say for that, um, kind of overactive mind,
Mm.
overthinker, one thing that it doesn't sound like it should work is actually scheduling worry time, which that sounds totally
Ooh.
counterintuitive. You're like, why you want me to worry on purpose? And it's like, what I'm trying to get you to do is to form yourself into a person that you are limiting the time that you are allowing yourself to worry. So
Mm.
it's not magic. Everyone always wants immediate magic results.
Hmm.
Any behavioral intervention that I give to someone, I say, give this a full try for at least 4 to 6 weeks.
Hmm.
You're actually practicing it every day. If you come back and you say life got in the way and you weren't able to practice consistently, that's fine. But
Mm.
we can't say that this behavioral intervention doesn't work until we've actually given it a good try. And so, if scheduling worry time is exactly what it sounds like, I'm going to have a time outside of my bedroom. So, I'm not in my bedroom. I'm not
Mm.
associating that as a place where I'm going to worry. I'm going to do it before bedtime. And I literally sit down and I just write out all of my worries. You're going to notice a little bit of a,
Hmm.
kind of bell curve there. And so a lot of patients come back on the second or third interview and they're like, Dr. Long, I am worrying more. So that's part of my advice first is, okay, you will notice an uptick because now you're actually giving your time space to worry. So your mind is
Hmm.
going to give you all of those things to worry about. And if you continue to practice it, eventually you will find out you are going to reach the limit of the things that you've worried about. And that's why I tell people to write it down, because then you can go back to, oh yeah, this is, I'm thinking about this, but that actually is connected to this thing up here too. And so, and then where this actually really helps for bedtime is then if I'm outside of my worry time, I'm going to tell myself, I don't have to think about this now. I'll think about it at worry time.
I love
and that
that.
does two things. Is one, it's, limiting yourself to have just that one point in the day so that the rest of the day you don't have to worry about that. But then two, I tell my patients, if it is really that important, you will remember it at worry time, because you can get into a worry where you're like, well, I'm worried I'm going to forget what I was worrying about. And that's like, no, that we got to stop that. And so that's why I tell people, if it really is important, it will show back up at your worry time. And then you can allow that worry to just go away. If you can't remember it later, that's fine. It's not going to blow up and be the end of the world kind of a thing. And so, yes, 1 or 2 days, you're still going to worry. Your sleep is not going to be that much different. But if you start today and you do that for like a full month, then when you come back, you can be like, wow, I not only have I like put all my worries down, now I can kind of use my worry time to start addressing some of those worries too. And I can start, maybe challenging some of them or making some plans on how I can kind of mitigate some of those things. And so it just really turns it on its head.
It's incredible advice, Dr. Long. Thank you so much. Guys, definitely check out Dr. Long on Instagram and TikTok, The Wholehearted MD, and find him online at thewholeheartedmd.com, as well as his book, sleephabitsjournal.com. Dr. Long, it has been an incredible conversation. Thank you so much for joining us.
Yeah, of course. Thank you for having me on.
Thank you so very much for listening to this episode of Shadow Me Next. If you liked this episode, or if you think it could be useful for a friend, please subscribe and invite them to join us next Monday. As always, if you have any questions, let me know on Facebook or Instagram. Access you want, stories you need. You're always invited to Shadow Me Next.